And welcome to our third session of the morning. I am Chris Schoen. I am a member of the class of 2016, and I'm really pleased to bring forth a panel that's going to actually take us down to the practical level, building on the work that we heard from David Zuckerman around anchor institutions, and then the panel about the business case, especially around social determinants of health. What we're going to do now is talk about a significant relationship between Cheshire Medical Center based in Keene, New Hampshire, and the larger community of Keene, as well as the greater Monadnock region, in terms of advancing not only population health, but addressing health equity and social justice. And I'm pleased to present as our panel Sean LaFrance, who's our Vice President of Population Health and System Integration. Tim Murphy, who's actually one of our community partners. He is the Executive Director of the Southwest Regional Planning Commission in Keene, New Hampshire. Tricia Zahn, she's the person who's actually doing the work. She's a partnership manager within our Center for Population Health at Cheshire Medical Center. And then finally, very pleased to have Dr. Yvonne Goldsberry, who's the president of the Endowment for Health here in New Hampshire. And what we're going to take you through is talk about how do you go out and build strategic partnerships throughout the community so that the whole community actually owns the work. And it's not just the anchor institution or the medical center. To give you some context, the city of Keene is located in the southwestern corner of New Hampshire, excuse me. And we have a population of about 23,000, but our overall service area that we really provide services to is about 131,000. We have a lot of the issues that Sally Crafts shared. We're rurally based. And so with that, I'm going to turn it over to Sean, who's going to begin our presentation and our discussion around creating community partnerships. Sean?
Thank you for the introduction, Chris. So I want to talk specifically about something Healthy Monadnock that you see on this slide. That is kind of the framework for a whole network of partnerships that exists in our region. And that is really a basis that we're using going forward in terms of addressing equity issues. As Chris mentioned, this is the hospital where I work, the medical center. We're a hospital, have about 22,000 ED visits a year, about 650 babies, 250,000 provider visits. Serving the region. We're also in the spirit of what we were talking about, anchor institutions. So we have about 1,400 employees. And the last time we did an analysis of our kind of economic effects of our hospital, we identified about $10 million a year in local purchasing power that our institution provides to the community, and also about, in terms of secondary employment, about 1,200 other jobs in the region as a result of the economic impact of Cheshire Medical Center. The geography Chris mentioned, so southwest corner of our state. We have in our area 31 towns and the city of Keene. So we have towns that range from about 670 residents to the city of Keene, which is about 22,000 people. It's a quite charming, bucolic area if you've had the opportunity to visit, but sometimes that rural charm, if you will, mass challenges that relate to the issues of equity and health. And I would suggest that involves transportation, and transportation meaning there's not a mile of interstate highway that touches any one of the communities in our region. Broadband cell service is sparse. And also there are just pockets of rural poverty throughout the region. We embrace the framework of social determinants, recognizing that the high quality medical services that we provide actually through the medical center is but one part of the larger issues of how we address the health and well-being of the people that we're trying to serve. I want to pause here because this slide encapsulates a lot of history. So our process at Cheshire Medical Center and the Center for Pop Health where I work is all about engagement. And engagement has led over the years to a series of deep relationships and various partnerships. On the left, you'll see in 1994, the leadership of Cheshire Medical Center convened something called the Council for a Healthier Community. This was a cross-sector group group that had business, civic leaders, elected officials, and nonprofits all coming together to talk and engage on the issues of what is health in the region. And going down the line there, you can see that we did community health needs assessments. Community benefits came into being in the state of New Hampshire in 2000. And then we launched something called Vision 2020, really setting forward a challenge and an engagement process to get the broader community involved in thinking about health. That subsequently sort of morphed into the framework of Healthy Monadnock 2020, and nowadays we've shortened it to Healthy Monadnock, in part because next year is 2020 and we know the journey goes on, and so we are at a point where we're looking forward to that. I just pointed on the right side for the people in New Hampshire to realize how various state investments have, over time, been made to build this kind of local public health network. And it all came together last year, where you see the Leadership Council for Healthy Monadnock. That's when we merged the state-required systems that came into being with the 20-plus year organization and group that have been doing this work. I wanted to use this slide just because you get to see our iconic symbol of Mount Monadnock, which is seen throughout the region. And the council governs our initiative, and the tagline is making the healthy choice the easy choice. We do that through a series of different kinds of partner organizations as well as champions, different categories of how we characterize engagement. It's engagement, but also alignment. So we know, for instance, on the issue of obesity, that we can do certain things as a medical provider for the region, but if we aren't also paying attention and working with schools, youth groups, other organizations, that our effect will be less than if we are aligned in trying to do this work together. Within the framework of what we do, so we have a community health improvement plan that we have merged the required one, if you will, for the hospital, along with the one that the state public health authorities ask for, and through a process of engagement have identified the 6 priority work groups that you see listed here. And I would suggest that in all of those groups, there are issues of equity to be addressed as we proceed in the work that we're talking about. I'll just mention here, this is about policy change, and you'll hear more about this from my colleague Tim. But we do things in a direct, obviously, care relationship with patients and such, but we're also trying to change the environments and policies that affect health of people in our region. We do also make great efforts to be focused and measure our outcomes. So we had some special funding for 3 years. We decided to target tobacco, nutrition, and physical activity. And we're quite successful in terms of reaching our goals in terms of people that we touched or engage. But I think what's interesting is if you look down on the right-hand side, you see the different types of organizations that are required to be partners to make this all happen. So many work sites, many schools, municipalities, and such, because it's based on the partner effect. But going back now to the framework, we're here to talk about equity. We also have seen it to be of importance to talk about disparities and to understand them within our own region. So again, at the overall level, we look like a great place in terms of a nice rural part of our state. But we also, you can see here that there are significant disparities related to income with particular types of chronic disease or smoking in this case also. So you see significantly higher numbers of people with low incomes having these diagnoses or this challenge with smoking compared to higher income households. And if you'll note in the lower right corner, part of this is our work. We recognize that the economics of all of this matters. So we have launched and worked closely with our Chamber of Commerce on a living wage campaign. You know, New Hampshire is one of the states that has never raised its minimum wage, so it's like $7 or something an hour. We know that's not a livable wage. And so in our region, it's been pegged at about $15. And so we are working to set that as the baseline or the platform for jobs in our region. At the patient level or the healthcare center level, we're also trying to examine the issues that our patients actually have related to social determinants. And we're fortunate to have funding from the Dartmouth-Hitchcock Health System to do our Prescribe for Health program. This is embedded within primary care, and we started it in 2017. We've served 433 patients and have had a pretty steady increase in the number of referrals. And the way this works is that if somebody goes into the doctor's office, they're asked a couple simple screening questions. If they have a chronic disease, do you anticipate any barriers to being able to follow through on the recommended treatment that is being offered? And do you have somebody important in your life to help you, support you through this process of dealing with your chronic disease? If they answer yes to either of those questions, they're asked if they would want to be able to talk with somebody about how to address those barriers, and that results in their referral to a population health worker. And you can see in the lower right side the types of frequencies, if you will, of the types of barriers that people have identified among this 400 that we've served to date. I would add that, interestingly enough, the population is a predominantly older population that identifies these issues, and they average 2 of these social determinant problems. It's a very relational type program, so what happens when the referral comes through Epic to the pop health worker, they have 48 hours to reach out by phone or in person with the person. And then they do a more in-depth sort of questionnaire screening. And once those barriers or challenges are identified, then it's the question to the person is, what would you like to work on first? And this approach, they'll work through the list and up until 6 months as the extended time frame if needed. And finally, this platform of Healthy Monadnock and the culture of health we've been creating over the last 20 plus years is really giving us an opportunity to address diversity and inclusion issues. So what you see here is, well, first of all, you see an image of the future in our country and in our region with all those kids. But this is a resolution that was adopted by our hospital board of trustees in January following discussions we started with them in the fall. And we're specifically having that level of commitment to the issues of diversity and inclusion. And we're specifically going to start with race and ethnicity as the focus of diversity. We have about 3% of the population within our region are people of color or Spanish-speaking primary language, so the numbers are small, but not insignificant, and that we have got to tackle these issues proactively so that we do create both not only a workplace, but a community where everybody thrives and people are not just accepted to come into our community, they need to be welcomed. And that's the distinction I make in terms of inclusion. So with that, those are high points, and we'll hear more.
Again, I'm Tim Murphy. I'm a regional planner by trade. More years into it than I'm going to say. I've been in my current position with the Southwest Region Planning Commission for nearly 25 years, serving 33 communities in a rural region, all of Cheshire County, about an hour south of here, in the western half of Hillsborough County, for those who are familiar. Sally mentioned earlier this idea of rural America, and so it's not the same as urban America. Well, that's definitely true. The disinvestment that's been made in rural America since the Great Recession is really taken root in some of the area that I serve. A lot of it just makes my job a little more challenging. And so what is planning, community planning, regional planning, urban planning in a rural setting? So land use, environment, infrastructure issues like transportation, water and sewer, broadband, housing, economic development, emergency management, and more recently, public health. So several years ago, I was recruited to serve on the FAC, the Public Health Advisory Council, the LCHM, the Leadership Council for Healthy Monadnock that Sean made reference to. You know, and I met a lot of new people representing a full spectrum of our sectors, which is really important. I also learned that there's a whole universe of new acronyms out there. I soon learned also that we're all pretty much doing the same thing around that table. We're trying to make our communities better places to live. So I've got some, I guess I would call them examples of partnerships. And that's what this panel is about, right? Valued partnerships, and I value my partnerships with everyone who I'm sharing this panel with, for starters. So with these examples, though, I found out late last night that my coworker who helped put this together said, "Oh, and I put animation in," and he was all excited. And I said, "What does that mean?" So bear with me as I try to get through this here, and I've got my my script too. So we have a problem with fine particle air pollution in our valley topography during infrequent atmospheric temperature inversions in the winter, which trap particles near the surface to be breathed in by humans. So the culprit is residential wood burning. We're talking particles a mere 2.5 microns in diameter that can be inhaled deep into the lungs, triggering reactions in those with asthma and related conditions. So we live in rural New Hampshire, so we're not about to outlaw wood burning. So what do? We create a partnership. We get the facts and go ahead and develop some effective messaging in the form of brochures and posters and doorknob hang tags and presentations and public service announcements, press releases, and deliver a public education and awareness campaign that is designed to influence behavior change. You know, the whole idea is to inform the community about how we can all play a proactive role in reducing our reliance on residential wood burning during the literally 3 to 4 days per year in which temperature inversion is forecast for our area. We've participated in a couple projects looking at relationships between climate and human health. Whether it's an increase in extreme heat, vector-borne disease, heavy precipitation, flooding, ice storms. Again, the work entails creating a partnership, understanding the science, identifying vulnerable populations, selecting appropriate interventions, and ultimately implementation. In our experience to date, interventions are based on educating vulnerable populations to the risks and the protective actions that they can take. This next example is a little different. The idea here is promoting active transportation for a variety of reasons, including good health. You heard Sean make reference to a project that had 3 focus areas. One of them was active transportation. And in this example, we respond to the vision as articulated in a community's master plan. Phrases such as provide access to healthy living, safe, livable roads, and adopt a complete streets policy. So the vision in that master plan leads to complete streets demonstration events. Maybe you've heard that term. You're about to see what it is. Demonstration events are temporary setup featuring dedicated bike lanes, crosswalks, pedestrian corridors, landscaping, benches, art, mini parks, and more. The idea is the community members have the opportunity to directly experience and comment on complete streets treatments. And if all goes well, guidelines and a policy are developed, reviewed, and adopted by municipal government creating local regulations, and that's kind of a big deal. Once in place, the policy guides on-the-ground implementation. So although a local master plan might serve as the start of something good, a partnership is critical to the process. The last example is a response to changing demographics. With the rapidly aging population combined with a decline in younger age cohorts, we're undertaking an age-focused planning initiative in partnership with the Tufts Health Plan Foundation, the New Hampshire Department of Transportation, and the Cheshire Medical Center, many other partners as well. The fundamental question is, what could and should our communities and institutions be doing to be better prepared for these changing demographics? So just a quick snapshot. From 2010 to 2040, we're expecting to see a near doubling of our population 65 and over. In a decade that ended in 2015, K-12 enrollment dropped 17%, and similarly over that same time period, working age adults 25 to 39 dropped 15%. So a lot of issues we need to be focused on. We've identified 4 themes in this initiative. And products will include a regional report complete with data, trends, findings, and recommendations, as well as individual community profiles with suggested strategies and best management practices for the communities that we serve. So these just some examples. I hope they help in some way demonstrating the value of effective partnerships.
Good morning, my name is Tricia. I am the partner manager out of the Center for Population Health at Cheshire Medical Center. And I've been asked to share with you this morning some examples of some on-the-ground work that we've been doing, some perspectives and opportunities that we've had, along with some challenges. So I can also be considered kind of a positive partner poker. So the work that I do is with eternal optimism. I'm filled with hope. I'm filled with excitement about the things that we can do and the passion that we have in our region. And a lot of my job is about poking people. A lot of my job is about reaching out, asking them what we can do to help, and then encouraging them along the way. A lot of people have competing priorities. So we know that when we go home, we've got priorities at home. We go to work, we've got priorities at work. Our boss gives us new priorities that we didn't have yesterday, and how are we going to balance those with everything we already have going? We have that same thing with community members. There's a lot of excitement, there's a lot of drive to do certain things, and we know that that doesn't last forever. So how do we capitalize on that? And then how do we continue to move that forward once the idea has passed? I do a lot of accountability. So a lot of what our community members do matters, and it's that idea of closing the loop, that if they're part of a certain project, that they're part of something larger, and how are we showing them that? How are we reminding them that they're something, a piece of something that's much larger? I do a lot of support, so it's helping folks thrive and it's filling those gaps. So I do a lot of creating the space for other folks to create the solutions, a lot of listening more than we're talking. It's the idea of being community-led. So we have these assessments and things that we can do, and we can use data that exists from census or from YRBS, and we can bring folks to the table and then asking them to kind of help us with whatever their solutions are, that it's community-driven and it's not coming from us. And we're looking to find and foster community champions. So who are those folks that exist in the community that have the answers, that just need us to get out of the way? It's not even a conversation anymore about empowering folks to do the work. They have the empowerment within themselves. It's just us getting out of the way and supporting them in whatever needs that they can come up with. We work a lot with 100 Million Healthier Lives. We've been lucky enough to be part of their SCALE initiative, spreading community accelerators through learning and evaluation. And a lot of that work has helped us realize whose lives are getting better because we're here. How are we regularly asking that question, and asking the question of who's not yet thriving? Those questions can help us guide our priorities, can help us guide our work, and can help us determine what our priorities are moving forward. Like you heard from Sean, we have our community health improvement plan. We're looking at going as upstream as possible. We're looking at finding root causes, the reasons why folks have negative health outcomes, and how can we go as upstream as possible to have an impact on those. We know that change moves at the speed of trust. And so how are we working with community members to hear their voices, to meet them in their space, on their terms, and follow through with what we promise to do for them when we leave that space? Like was mentioned before, the idea that if you get invited back someplace, that's already a token that you have in fact made an impact and that you're being welcomed into that community to serve a certain purpose for those folks. So one of our priority areas is food access. So an example that we have of that, of an on the ground, is in Hinsdale. We've been working a lot around their food access. So data led us to know that Hinsdale was an opportunity to try a place-based intervention. The number of assets they already had led us to Hinsdale to try this opportunity. So we're looking for bright spots. We're looking for places where things are already going well, and how can we foster those, accelerate those, scale those up, instead of looking at our data and finding out who's the worst and going and targeting some interventions there, feeling like they're, like you heard before, they're in the yellow. We're good enough there. Let's move on to who else, who's the next worst. Let's do a little there. Trying to think about it the other way around. Who's doing really well, and how can we kind of scale that up and then accelerate that to other folks? Using it as asset-based. Our place-based project is the idea that we want to start small. You want to test an idea, the idea of improvement science. You want to test a little idea, see if it works, let go of it if it doesn't work. There's a lot of power in standing in front of a group of people and saying, we had an idea, we tried it, and it failed. And I know it failed because I measured it from the very beginning, and I made a prediction from the very beginning on what was going to happen. It didn't happen. And if I had a happy accident, amazing. Maybe we can move forward with that in another way. But if it doesn't work, how am I being humble enough to say, I had a good idea and it didn't work, and I'm going to let it go? And what's the next idea that we're going to tackle? We work a lot with other partners. So I'm not the subject matter expert in food access. I have the ability to bring people together who are the subject matter experts on food access. So we're finding folks that are food insecure, and those folks are helping us with the answers. We're bringing together Cheshire County Conservation District, who does a lot of work with farmers. We're bringing together Monadnock Farm and Community Coalition, who does work with community coalitions and farmers. We're able to create that table to bring those folks who are creating those answers for us. We have over 10 access points in our region for SNAP, Supplemental Nutrition Access Program. And so we're looking to move from increasing access points to increasing utilization. So the idea of build it and they will come isn't always true. And so if we built it and folks aren't coming, what is that answer? I could stand here and decide it's transportation, it's childcare. Those are the reasons why people aren't doing the things we're asking them to do, and that's absurd. So how are we bringing these people to one table, to different tables, meeting them where they're at, bringing them food, having child watch, engaging them in conversations that are not about my position, not about my credentials, but the fact that I'm a wife, the fact that I grew up in New Hampshire, the fact that I enjoy snowmobiling. Like what's an angle that can get folks on a person-to-person level that we're doing human-based interventions, we're not doing position-based or credential-based interventions. We're also working on farm share programs. So these are opportunities for folks that are in a gap area. So they don't have a low enough income that they are eligible for a handful of programs, yet they don't have a high enough income that they would consider themselves food secure. And so how are we opening up opportunities for those folks to have access to local nutrition? We have a lot of farms in our region. We're very lucky in that way, yet a lot of the food that our residents consume comes from outside our region. So we're working to change those pathways. We also have a Vouchers for Veterans program, which is a pilot. The local folks in Hinsdale decided that they thought that it would be a good idea. They're super proud of their farmers market, and they thought it would be a good opportunity to show some support for their veterans. So it could be access to local food, and it's also social connection. So we provided vouchers for veterans. They could come to the farmer's market, show a valid ID, be able to receive a voucher, and be able to use that money at any place at the farmer's market, including hot food, which a lot of nutrition programs, you can't buy prepared food, you can only buy certain produce, or you can't buy dairy or cheese, you can only buy fruits and vegetables. And so we created that opportunity for folks to increase nutrition as well as social connection. And we've got testimonials in their handwriting about how that meant to them, that connection. We've got ones from wives that are super proud that their husband was had a reason to kind of come out and mingle with the community, and that they're hoping that we can continue this program in the past. So I'm just going to touch on a handful of challenges and opportunities. So some of the challenges, like I mentioned before, is kind of keeping that momentum. Things are changing all the time. So how are you having those regular touches with folks that they know that you're still engaged, they know that there's still interest, yet they're not feeling overwhelmed or burdened with their connection with you? A lot of follow through, a lot of closing loops. So I'm very clear when I start with community members about expectations. When we started in Hinsdale, we had no idea what was going to come out of it. Just humbly entering their space to ask them if they're interested in opportunities and then letting them answer those questions for us. I didn't have a menu that they were selecting. We kind of organically started those conversations and making it really clear with them that we're going to see what works and I'm going to tell you what we're able to support and what we might not be able to support right now. So we're willing to ask those questions even if we don't have those answers because we start with that from the very beginning. So we're not have this false pretext of I'm here to solve all the problems. One of the challenges is staying away from pseudo priorities, meaning following the money. So sometimes in nonprofits and population health, we get a little excited if there's a new funding opportunity and we kind of go towards that angle. So the idea of kind of staying away from that the best that we can and continuing to follow what the community needs are, not what the top-down money opportunities are. We struggle a little bit with balance. I could be considered a backbone staff. I could be considered somebody who supports community projects and making sure that that relationship is clear, that it's not just Trisha's ideas, it's not the Cheshire Med show, it's not that we're kind of forcing these things into the community, it's that I'm there to support them, but they're really driving the process, and how are we making sure that's clear at all times? And it's not just lip service, but that's what's really felt. We work a lot on cultural humility, moving a little bit past cultural competency into this idea that things change, things evolve, not all people are the same. You might have a conversation with some folks and use certain language that they're great with, and you have a conversation with somebody else, you use language and it's not their chosen language, and that's okay. And how can I be humble in that I'm open to what that looks like for folks and sharing that with community members? Becoming comfortable with uncomfortable conversations, and how are we moving and advancing that in our region? That we have a lot of privilege and we have to have these tough conversations. That we can still have very racist systems without folks identifying as racists. And how are we navigating those waters for folks that are like, no, that's not me. It's like, yeah, but you've got a lot of power in this situation and you're continuing this system. And how are we going to dismantle this together with the privilege that we have instead of being like, no, that's not me. I'm not the person that's part of this. We want to measure what matters. You heard this morning that what is the point in measuring everything if you're not going to do anything about it? We can look at all realms of social connection and how are we focusing on those that matter and advancing those instead of asking them a bunch of questions and doing nothing with the majority of the things that we're interested in. We have a willingness to learn, and we use a lot of community champions. So we're using this data over time and the opportunity to learn new things every day. So we do a lot of community-based work, and that can involve businesses, schools, nonprofits, for-profits, social services like our community kitchens and our shelters. And we're excited about the opportunity to use these lessons learned with different communities and then scale them up as we can. Thank you.
Good morning. I think it's still morning. I'm Yvonne Goldsberry, and I am president of the Endowment for Health. The Endowment for Health is a statewide healthcare conversion foundation. For those of you who don't know what a conversion foundation is, we were born when Blue Cross Blue Shield New Hampshire turned into Anthem. We're turning 20 in October. So it's my actual privilege to be sitting in the seat of president right now. I've been there about 5 years. So I partner with these guys, and I actually came from the Cheshire system before arriving in the position I have now. So it's always a treat when I see the work advance and I get a grounded understanding of what the new challenges are and how can we as a funder support the advancement of these types of initiatives. I'll bet in every community that is represented here today, you have some health conversion fund that's hanging out there waiting to work deeply with you. And I was happy to see on David's slides, philanthropy being one of the critical partners in all of this. One of the important roles that philanthropy often plays is to be the other poker. We can poke and provoke new and deeper conversations. And you see health conversion funds all around the nation doing that, stepping forward to try to bring health delivery systems together more closely with their communities. Many of us are now funding in what we call systems change, and that's a big, broad word, I think, systems change. And for those of you in this room, probably system to you means the health delivery system. But to us, it means really addressing the systemic issues that cause a lot of the problems that people have that end up having you assess their determinants of health. So whether it's racism, sexism, fill in the ism, we want to focus on those things. So for example, at our organization, we fund a lot of advocacy and advocacy capacity. So underneath a lot of the work that's here are the questions coming forward to our state legislature that might actually impact policy change to allow Tricia to have partners at the table equally. We work to build broad-based coalitions that are quite like Healthy Monadnock. Actually, some of them are modeled after this, but on a statewide level that allow initiatives like Healthy Monadnock to connect to. So for example, the Alliance for Healthy Aging is a relatively new piece of work for us that brings together at a statewide level similar partners that you hear about here at Cheshire to address the issue of aging in our community. And the work that Tim does is plugged into that alliance so that we can bring the learnings across the state as they come up. That said, what we're learning at the statewide level is that it's one thing to bring our focus on practice improvement, and it's another step forward, you might agree, that we would focus on policy change. But yet those two things alone are really not getting at the intractable issues that cause people in our communities to really be in the circumstances that the healthcare system should end up being sort of the safety net provider of last resort. So our work now talks about some other things that haven't really been mentioned but have been implied in the comments so far today. So we're now talking a lot about how are resources really distributed? Like, where is the money and where does it really need to be? And how do we get the money from where it is to where it needs to be? And in healthcare, and I know as a hospital administrator, we were always really talking about that. And anytime you wanted to do anything that was a step beyond typical community benefits, you ran up against, there's no way to pay for that. So how do we break out of that? How do we have new codes? How do we have new positions that are paid for differently? How do we redistribute the money? How do we actually stop paying for things that we don't need to pay for anymore? Big question. Another big question is our networks. We're really limited by the networks that we can see. So I know in my case, I have a dog and I have a lot of friends with dogs. And I love my friends with dogs, so I don't have a lot of friends with cats. So if you asked me to invite cat people to my dog party, I would be hard pressed to how to do that, because I just don't know many cat people. So the same is said for our networks when we want to try to focus on DEI type work. I often, as you imagine, in New Hampshire, spend a good deal of time with people of European descent, and I spend a lot of time with them, and that's their network. And they say, how do I meet other people? Because that's all they have in front of them. I also spend a significant amount of time with our communities of color. We're asking the same kinds of things, like how do we bust up the networks that we've already had? And I would propose that these networks are a critical barrier to any of the work that we're talking about today. We have to break them apart. Another thing that we talk a lot about, and Tricia started to get at it, is power. And how is power distributed? How is it concentrated? Who has it? Where is power starting from? And how do we transfer power? So we've been doing a fair amount of work really at the grassroots level to help individual people understand how powerful they are, because everybody has power. And you just forget that you do. And so working with sort of grassroots organizers to lift up the voices, so when you're looking for your community voices, oftentimes your local philanthropy might be investing in those voices. For example, one of the projects that we're working on is PFACs. And so you've got PFACs in your hospitals, you've trained them to be great voices inside your system. They're participating on communities, you trained them up in quality improvement and all of that. How do you have them help you talk about your community? You've ready-made access to the people in your community on your PFACs. How do you take your PFAC to the next place, bring it out into the community? Distribution of power, I would say, is getting in our way of making the changes that we're talking about today. Lastly, it's the narratives, the mental models that we have about the people that we serve, about the conditions in which we live, about just about everything, right? So if I take the issue of the opioid crisis, up until very recently, we were still in a blame the addict place. Oh, if they could just detox, they'll all be better. And we're now coming to a really clear understanding that this is a systemic societal problem. We need to approach it differently. So changing that narrative about how we look at things makes a huge difference. And I would say that mental models and the narratives that we create around those are another thing that really gets in the way of making any of the changes that we've talked about today. So in philanthropy, one of the things that we're doing to work on that type of issue is investing in media partnerships. So in our case, we have a media partnership with the statewide newspaper, the Union Leader, that supports a reporter who's focused on aging issues. So any of you in New Hampshire, have you seen Silver Linings, that series at all? That's underwritten by us. Purposefully to raise awareness, to stop talking about aging and start focusing on healthy aging, to stop talking about elders and talk about older people. We're all getting older, no matter how old you are. So it's not about them, it's about us. So how do we start to change the narrative, change our mental models? So I would say those 4 things are the things that are really the next step for this kind of work. Where David started us today embodies that. So for health systems that are trying to distribute wealth differently through hiring from the local community or starting a new business, that's a place to start for redistributing resources. Working on how you feel internally about how you relate to your community, breaking up kind of that power dynamic in your network, and then starting to tell the truth, changing the narrative. So I look forward to our panel conversation, and these guys are my buds.
So thank you all for the interesting discussion. As I said, we were taking what we heard earlier in the day to the more practical level. And as I listened to our panel describe their role and perspective in these partnerships within the community, where do you see this evolving to? I mean, if I think about it, it appears it started with Cheshire Medical Center working with the community. My sense is it's still owned by the health system to some degree, but yet we want to move it and migrate it that the community owns it. So what do you see as the next steps in the evolution of Healthy Monadnock or these types of community partnerships?
Well, I think one of the things that we're doing right now, in part because we're marking the 2020 period coming up, is to reframe these concepts around a partner and a champion. So we were rather narrow in labeling those, and we want to broaden it to be more inclusive. The other thing is for a while, as I mentioned, this has been around for a long time. For a while, the concept of collective impact was the big buzz, and we tried to see how we fit into that. And we came to appreciate, I think, with some of the more recent literature on collective impact, is that if you're the backbone and you're, say, too much of the backbone, then the other organizations that you actually want to have them own and do this work can become dependent and look toward the backbone to do this. So we're remaining a strong force and resource, as Tricia was mentioning, but we're really trying to build on what I would suggest is in that our region. And I've only worked there a couple of years. I worked at a statewide level prior, and there truly is a sense, a culture of health and understanding of health, I believe, in the region of the state and others in its other areas. So building on that culture change.
So my perception for Healthy Monadnock is that the next step might be some of the strategies that David articulated, because I feel the anchor position that the hospital sits in, even if you back off from the community seeing it as a backbone, there's other sort of behind the scenes investments that could be made that would fuel the more upstream possibilities. So, for example, David mentioned the New Hampshire Community Loan Fund. There's a resident opportunity right there in Keene called Tanglewood, and the New Hampshire Community Loan Fund, as we speak, is looking for investment capital to secure that property for the residents that are there now. And that's an opportunity sitting there waiting, which would go a long way toward the housing question.
I just want to follow. So that is a great example because it's so real time. I was thrilled when he mentioned it. So these are 328 homes within walking distance of our hospital. We have employees and many patients, many residents who are our patients, and they're now, their affordable housing is at threat because of the land being sold beneath them. But this is a challenge when you're in a system also, because the system is the level where certain decisions be made about investment. But even at the front line, we're able to provide resources, some from the Center for Pop Health, to the residents there who are trying to organize and save their homes.
And I believe as we evolve, we're learning that we can't be all things to all people at all times. And that used to be our message, which is a very distracting message because it's just not true. And so how are we owning that and honing in our focus to, like was mentioned, more upstream opportunities, more root cause opportunities, a layering approach that we're not letting go of supporting projects, but we're also looking at policy, system, and environmental changes that are driven by the community, so that we can have those marked increases in health, and how are we tracking that over time and showing that to folks. So we've got a lot of work to do with the data that we collect being usable for community members, being visible to community members, so that they can see that the things that they're doing in their schools and their workplaces and their homes and their communities are having an impact to something larger. And so kind of honing in that focus so that we can have a really clear message that we're standing behind as a community to make that positive change.
And I'll just add, we talk a lot this morning, and we're familiar with the social determinants of health, and having worked with those kinds of issues for decades, prior to becoming more involved with the public health planning sector, it's clear to me that there is an extreme need out there in our community. So when you ask about the trajectory and the evolution, and so clearly, in my experience, the public health sector needs to be much more integrated, and that's what's happening in our region with the partnerships that we're talking about with this panel.
So Tim, as we talked before the session, you being from a totally different world than most of us who are sitting in the room, what advice do you have for those here in terms of how do you build partnerships in the community that are sustainable and long lasting? I think Tricia referred to building that trust. Any advice that you could give us in terms of how we can go back to our community to truly engage so that it's a true partnership?
Sure. First of all, it's hard work, and I assume you would want to do it. And assuming you want to do it, it's important to get out. It's important to network. You need to infiltrate, if you can call it that. It's happening. So show up to the meetings, speak your mind, listen. Trish made a great comment earlier. When you show up on their terms, not yours, right? That's really important because that's how you build the trust. Always seek multi-sector participation. If you want to get buy-in, if you want to get implementation, it's not going to come from a single sector. So I'm talking government, looking at education, business, and healthcare, and more. So you want to have all the players at the table. That's how you kind of sort things out. You want to get your facts, right? You want to know the science, because then you can speak compellingly, and you want to quantify what the issues are, because you're ultimately trying to bring others under your tent, and get everyone under the tent, because it's us, as Yvonne points out. So tell a compelling story. Touch on fiscal impacts. How does it affect the pocketbook? Recognize that your elected officials have limited bandwidth, right? There's only so much that they can champion. They're being hit left and right with all kinds of issues, and again, only so much that they can focus on at any given time. So your story has to be more compelling than the other story, and the way you get to that more compelling story is with the facts, with the science, with the statistics that help paint that picture, and tie it to the fiscal impacts that, and the efficiencies of certain approaches that can help ultimately save money. So, and then I guess the last thing I would say about that is have the confidence that multi-sector agendas, when they align, is a beautiful thing, and the chances of something happening are much greater.
Thank you. So Yvonne, when I listen to you speak and you talk about what I call the four things that are compelling us to move forward, what can we do to shift the paradigm? How do we move those changes in our mental model, the power dynamics, I don't want to say redistribution, but how you shift community wealth? What are you seeing out there others are doing that maybe would benefit us to think about in our own communities?
So I think Healthy Monadnock has the beginnings of great things. One of the biggest ones is talking about a livable wage, and actually taking action around that and standing up about that, and the hospital sort of saying that out loud. I think part of the problem with these conversations is that we're not just explicit in what the systemic issues are. And as I said earlier, it's all the isms. Those are the systemic issues. And we're too afraid to talk about them out loud, and too afraid to talk about them in multi-sector partnerships. But my experience is when we bring multi-sector partnerships together, there's at least a handful of people in the room who are willing and able to start a conversation. You have to be brave enough to, I hate the expression, but lean into it and own where you are. Understand and own your own opinion and where you are, and then lean into the discomfort of it. I think if we don't, someone earlier mentioned that about really being explicit about the underlying conditions that are causing us to have the problems that we have in the United States. And I think if we don't start from that, we're always going to just cover them over. We're just going to sort of cover it over with another CPT code or something. So